Hey everyone, this is the Manips and Sips podcast featuring me, Dr. Jeremy Boyd, and my partner in crime, Dr. Brandon Cruz. Today we're going to be talking about adhesive capsulitis, or better known as frozen shoulder, just kind of how things are, how things have evolved, the research, and how we approach things. Before we get too much into the weeds of it, let me pass it off to Brandon. How's it going, Brandon?
Hey, Jared, thanks for the introduction. Excited to talk about this topic. I know we've been talking about this recently as this conversation came up in actually one of your fellowship threads, and I figured, let's not just keep it there. Let's record and talk about it for our audience. So that's what brings us here today. Before we get going, let's talk about our drinks. I have my Johnny Walker 18 that you got me. Where is it actually? I have it here. Made a nice dent in the bottle. You got me this from my birthday a couple years ago. I'm drinking it. I'm in the office, so I don't have a snifter or anything. I have a coffee mug, which a student got, saying cracking necks and cashing checks, cracking backs and dropping facts. I think this is both? The dropping backs side. So that's
nice
mug here. So that was a really good gift by an intern of mine. So what do you got? What do you got today? I know you were brewing a porterhouse, or not porterhouse, like a porter with bourbon mix. Is that what you're drinking today, or that's not ready yet?
No, that won't be ready for at least 7-8 more weeks, unfortunately. So I over the weekend brewed a bourbon barrel porter style beer. So it'll be kind of cool. This will be my second batch that I've made. In a couple weeks, I get to add some the bourbon into the mix of it. So I'm excited. I'm a big porter person, also like bourbon, so should be right up my alley.
How long is that got to sit in there once you add the bourbon?
So
7 or 8 weeks and then add the bourbon, or?
Yeah, so it's 2 weeks in the primary fermenter, which is what I poured everything into when I first made it. So after 2 weeks, then transfer it to a secondary fermenter. So it's pretty much one big bottle to another big bottle. And then after it sits there for a couple weeks, then I can add the bourbon and have it sit there for a little bit. And then I can bottle it, and then it sits in the bottles for 2 weeks. So overall, a couple.
It's about summertime.
Yeah. So right when you want a nice,
I was gonna say nice
kind of porter. Yeah, but definitely
want let it sit, and then we could crack it open in the wintertime.
Yeah, that's a big thing. It's like you kind of pump out almost 50 beers with this sort of stuff, and so I'm gonna age a couple of them, keep them at 15 or so, and then have them in the winter, and then age them for a couple of years afterwards. But nice. As long as I didn't screw it up, did have one faux pas. I did burn one of the lines into the chiller as I was doing it, so we had to do a little triaging. So it was a lot of colorful words came out there in that moment.
I gotcha. You put your SCS knowledge to use there. With
exactly. So just put it on ice. That was the solution. So
there it is.
But for today, I'm drinking the 609 Indian Pale Ale from Glasstown Brewing Company. My last student, Jamie Parent, who's taken her PEAT exam to pass grad school, gave me that on her last day.
Nice.
So really good IPA. Huge fan of Glasstown Brewery. It's in Millville. Small brewery, been around for a little bit. It was probably the brewery that I had the most beers from, but never actually been to till recently. That's actually one of the last breweries I went to before COVID and everything like that. So awesome brewery. And for my glass collection, drinking from Ocean Lab Brewing, and that's in Isla Verde, Puerto Rico.
In there.
Yeah, awesome. By far one of my favorite brewery scenes of all time. Just it's on the beach, stunning, great music, second level. So if you're ever in San Juan or close to that area, highly recommend that you guys go to see that. But cheers.
For you guys out there who don't take interns, you should, because you get some cool stuff along the way. We'll plug there if you're good to them, if you're nice to them.
Yeah. At this
So
point now, I get mostly alcohol. I mean, you seem to
yeah,
get more
yeah, I get
glasses.
exactly. I
Just
get
what are you
some
getting?
clothes. I get like some quarters.
Clothes.
Though. I got a couple quarter zips because that's pretty much all I wear in the clinic over my
Eh,
polos or quarter zips.
that's a nice one too. So, um, but yeah, I guess we should move on to our topic here.
Yeah. Without
Adhesive
further ado.
capsulitis. Um, I guess should kind of talk about, or I guess there maybe our past experiences. I think sometimes that's what we've discussed in previous episodes, or maybe what some people are continuing to do
Yeah, I
in
was just gonna say
regards.
let's kind of switch it up a little bit. Being that your fellowship, I guess, discussion board was kind of what sparked this. You mind just giving us a little insight? I guess what the question was, what your response is, and then I guess I'll chime in with how I would treat it or what I typically do to treat, and then we'll kind of dive into the evidence and some stuff like that.
Yeah, sure. That works. The question was is from our virtual rounds through my fellowship with the Institute of Athlete Regeneration. And the question came up. The rounds finished actually online, and we had like a video chat first, but then we were going at like 2.5 hour round there, and we had to end it. But the rest were posted up, and we can all chime in at our own will there. One person asked what they have apparently a client who has adhesive capsulitis, and what were some recommendations or treatment strategies to treat them, potentially distance based or based off of the current times. Uh,
Via telehealth, then.
via telehealth, or I guess minimized of some sorts. Didn't exactly say telehealth, but something of that nature. Um, and then Toko, who's the director of our fellowship, awesome therapist, he was just kind of chiming in and saying that, for a lot of his early on adhesive capsulitis, is he doesn't really have a hands-on approach. And so I just kind of chimed in, and I believe in a huge hands-on approach. There's some research to support it, so I backed up with the research talking about high velocity, low amplitude thrusts and a regional interdependence approach. Um, and that's kind of what that me and you were starting to talk about it, and that's what decided to make a episode out of it.
Yep. So I guess with that, for the for our viewers out there, I guess what were your recommendations? How would you treat it? I guess how would you treat it in the clinic? With the full capability, I guess, of your repertoire arsenal, and then how would you treat it remotely or in these circumstances where it's most likely via telehealth?
Yeah, so in my, I guess, the ideal world, and I believe the ideal world of physical therapy is, the classic interaction between therapist and clinic and patient. Telehealth is a good option, but I don't think it's a means to an end or something we should all just shift. A lot of businesses are going to be switching over to telehealth or not telehealth, remote working,
Mm-hmm.
even after everything's figured out. But I think physical therapy, the real benefits is that kind of close to close interaction. But
There's power in
I
touch.
regress. Yes, touch and just casual human interaction that picking up on cues that you can't really see on TVs and or tele yeah telephones or on
Video
your
chatting.
view chat. Yeah. Um, but ideally, if they're obviously with adhesive capsulitis, there's going to be some range of motion, and we know that the joint becomes restricted. That's one of the clinical presentations and signs, whether it's a capsular pattern, just showing and limitations of range of motion, both actively and passively. So my main thing is to start off predominantly with manual therapy. I like to get things going first, get any sort of neurophysiological effect that I can decrease pain levels, and then have the client, capitalize on that. And, then they're doing their exercises. And then while I'm doing that's when I start to discuss things, whether it's, pain signs. We know some of these individuals are, have high stress, shit hit the fan for them in life. Also talking about some other things like comorbidities, diet and sleep, and we know about diabetes and its impact. So that's when I'm starting to have my conversations, try and do my best to have them as we're mobilizing. So I prefer to do the more translational or your classic, joint mobs, because they seem to be more effective. I'll also treat from a regional interdependence thing. We'll talk more about that. And then, go in and try and teach the client. I always tell my students, and something I practice, if you do any sort of joint mobilizations, you should probably facilitate with some sort of self technique, as best as you can. Some self techniques just aren't as good as a hands-on technique. There's very few, if any at all, self high velocity techniques. I'm sure you can. I mean, some people just go, just either self joint techniques. There's some distraction techniques where they can distract the joint, self AP glides, self inferior glides. So try and teach them that. And then following up with, trying to restore, some range of motion in a pain-free manner versus what I used to do, where just keep walking, do the inchworm up the wall, and keep going and going and going. There's your mark today, push a little bit more. And they're like, okay. And then the next time they came in, they're 5 pegs down the day before, the session before. So, and then, I put a little bit, probably more of an emphasis on treating the strength deficits that may happen, and obviously the motor control pattern faults that are happening, just, upper trap compensations, those sort of things that I just didn't really focus on early on. Just was like, all right, let's just get the range of motion, addressing those versus just purely stretching and getting the range of motion back.
Yeah.
Tend to get the range of motion back better than actual just typical stretches. So that's kind of how I would treat in the clinic. From a telehealth or a distance standpoint, I definitely, instead of obviously the hands-on sort of part, I'm jumping right into just, talking, educating. I haven't had, I'll be honest, I haven't had any telehealth clients for adhesive capsulitis, but if I did, it's jumping right into that communication piece, see how things are going. A lot of times our clients just need an ear for us to listen to them, talk about those same sort of comorbidities or their sleep habits, or, are they eating like crap and feeling like crap? And there's some, research talking about inflammatory markers from food and those sort of things. And then, jumping more into maybe those self-mobilization techniques. And then the same thing, I'm looking and seeing how they're moving. I'm surprised. Thankfully, we're having, cameras like 4K and stuff. It's easier to pick up on some of the motor control patterns now. So I'm addressing it just as I would. A little tough sometimes, because sometimes, obviously, even with motor control, I do like some guiding of the joint or those sort of things as they're moving. Yeah. Can't obviously do that. So that's a little bit limited. But other than that, that's how I try and, distinct the two. But what about you, Brandon?
Yeah, I think I'm going to backpedal to, I guess, the starting point. I always double check and make sure it's a true adhesive capsulitis. I feel like adhesive capsulitis and impingement are these umbrella terms that just get tossed around, especially by physicians, when they spend 2 minutes with a patient and then they automatically know what's going on. I think we need to do a better job in terms of making sure it's an actual, in this case, adhesive capsulitis, and that goes beyond it being a capsular pattern. I mean, multiple things could be capsular pattern. And we need to really, I clear out the neck a lot. I mean, I've seen some patients come in and you would think it's an impingement or an adhesive capsulitis hallmark, and you clear up the neck, and I mean, they've, doubled their motion by just treating the neck. You do that, that's probably not adhesive capsulitis. They're probably having some ridiculous stuff, and I've had people come in and not be able to raise up their arm at all, this height, because of acute pain that's going on because of their neck. And we go through the stages here. We're taught stages of the freezing stage, which is the most painful, the frozen stage, and then your thawing stage. I think we're moving away from that a little bit. And Jerry, I know when we were talking about this, you had brought it up. It's just like, what would you say, irritable and not irritable stages, basically, is what we're at now.
Yeah, actually, my employee, my therapist who also works, and he's going through a temple residency, is like what he's learning and what's the
Justin,
most up to date.
right?
Justin,
Yeah.
yes.
Props.
He was just like, he was mentioning, it was just like, yeah, now it's no longer like freezing, frozen, thawing, and all that sort of stuff. It's painful state, non-painful state. That's it. More of like there's no, I think there's a lot of people, or a lot, even research, trying to delineate or figure out when each phase started and ended, and how to know when one started and which one ended, what treatments are best at whatever one, and really just simplify it down to painful, non-painful. So yeah, and I was like, yeah, I mean, that's really what it is. It's I don't think anyone has a too good of understanding between freezing and frozen.
Yeah.
In my opinion.
I mean, that's constantly changing. I think the one constant is that we don't always know. And, the research that is done is guidelines. It's there to kind of help you decipher what's going on, but everyone's timeline is going to be different. So you can't go by, those first, I think what was it, first 3 to 6 months was freezing. And then month 6 through 12 was frozen. And then month 12 through 18 was your thawing. At least that's what it was when I was studying for the OCS. Like, we can't always go by those guidelines. Or those timelines. Everybody has a different timeline. So if you're going by what you learned in school, it may be outdated. I think that's a little bit of a problem with our profession, especially now we're coming out with doctorates, and we have been coming out with doctorates. Everybody feels like, I shouldn't say everybody, there are a portion of therapists who feel like their education has stopped when they've graduated, and they do like the bare minimum, and that is it. And I don't say this to try and belittle or berate people. We're no better just because we've decided to really go down the rabbit hole of residencies and fellowships and stuff. But I say it because I think if you're still predicating your treatment philosophy of what, you learned, I don't know, 5-10 years ago, or whatever the case may be, and you really haven't changed your treatment paradigm, in about 5 or 10 years, you're doing your client a disservice. And that's unfortunate, because pretty much everybody who has gotten in this profession has said they want to help people. Well, are you really helping people to the best of the ability if you're not kind of staying up to things? And really what it comes down to, like you said, like we learned it one way, and it's now kind of evolving. I guess our best version of treatment, I mean, that evolves. Like you and I have looked back, and we were like, well, we missed the boat on that one. Like, we fucked up. But I think as long as you're making the steps and taking quality courses, or maybe not even courses, but staying up on the research, and the more you learn, the more you understand that you don't know. And then now that's like a power in itself, because that allows you to be like, okay, I have, these different variables. Let me take a step back and see which of these variables or which of these guidelines or articles apply to this patient. And that's what it really comes down to. Are you versed well enough in the literature to then be able to, pluck it out and then be like, okay, this this subset or these guidelines apply to this patient, and maybe this guideline applies to this patient, because at the end of the day, it's an N of one. So I think we need, to do a better job of that. Understanding, like you brought up diabetes mellitus. A lot of the patients who have diabetes, I mean, if we're just going by the stats here, they're women in their fifth decade. Women are more common than men. People who have diabetes or thyroid issues or have had a heart attack, a myocardial infarction, or some type of trauma are probably the people who have true, true adhesive capsulitis. And then we also have primary adhesive capsulitis versus secondary. So I think before we jump into treatment, we need to understand what are the driving factors or possible driving factors that the patient's dealing with. And I see you have this slide up. Could you put that up there again? I didn't get the chance to look there. I was in my own world ranting.
Yeah, it was like you're talking about education,
expert.
so I figured I was like, yeah, this is a good one to put up.
Yeah. Basically, how much we know versus how much we think we know versus that one, right?
Yeah.
So what was the primary study on this one? I mean, I've seen this before, but I don't know.
This is a study. I just thought it was somebody nicely put that up there one day of, if it is a study, that's
yeah. So I think in the beginning we could all say, I thought I was a hot shot coming out of school, and even in school, I was like, I know a bunch of stuff, right? And then I started to learn more. I was like, I don't know that much. There's a lot more to learn, and then you kind of go through this pendulum here and how much I actually know. And then now I think we're trending towards is probably knowing a decent amount, but understanding or thinking that we don't know that much. So that's a sign of just becoming more humble and more of an expert in your area.
Absolutely. I always say there's so much more to learn, and every student's like, oh, you know more than anyone I've met. I'm like, you should talk to more people then. But I have a funny story. It's like I came out as a hot shot, got my doctor and everything. And did they give you the was it a quiz for your low back in the residency? Like just a competency sort of how you'd approach things, sort of?
I can't remember. During the back, I remember Heidi gave us like the start back in that quiz, but the low back section, what happened? That one?
It was legitimately like a quiz how you would treat someone or, certain things. I don't remember every question.
I can't remember. Maybe, I mean, you were right behind me, so unless they added it in, but I can't remember at this point.
I should ask Justin if he got. Well, no, he hasn't done the back yet. When he gets there, but I took it. I was like, oh, I'm gonna crush this bitch, and I can't remember if I think it gave the answers right there and then, but I got like crushed on it, and I was just graduating. I'm like, this is, I should know this stuff, and it wasn't that I wasn't taught it. It was just how things have changed so much. And just being able to tie it all together. So that was a quick drop from, I thought I had everything and went right back down. But let me just stop sharing this. But funny story about that. I got my ass whooped in like the first day of residency. But anywho, let's go back into talking about, you brought up some of those demographics or comorbidities that adhesive capsulitis people may have. I don't know if there was any other ones that you wanted to bring up, but then I figure it's like, what do you see clinically that would suggest, hey, this is definitely adhesive capsulitis versus, subacromial impingement, rotator cuff, bursitis, whatever it may be, or something from the cervical spine, obviously. We jump into that more of a clinical or objective standpoint.
So I'll say, to touch upon the first part about the comorbidities, I say women, definitely. I've seen more women with adhesive capsulitis than men. Usually one of the two. Sometimes I've seen both, diabetes and thyroid. I haven't seen too many not off the top of my head, even maybe one, and I'm sure there's someone in there that had a heart attack prior. So that one hasn't been held true for me. I've seen adhesive capsulitis secondary to trauma because of a fracture, or somebody. I've seen a couple who have frozen shoulder because the surgeon was way too aggressive in what the labral clean out that they did, and they got they received frozen shoulder from that, and also being immobilized too long. So those are secondary. To me, that's not even true frozen shoulder. That's just, we need to get you moving.
Mm-hmm.
But the other part was what? Differentiating. Is that what you said? And that kind of goes to
yeah.
Yeah. This would actually be good for, I know, another topic that you wanted to talk about, which is using manual therapy as our assessment. So, I'll screen out the neck and I'll note my impairments, T-spine, shoulder. I'll see if they have capsular limitations and things like that. But I want to see how they respond to my treatment, not even treatment, to manual therapy. So I'll play around with some posterior glides, some inferior glides, some combined motion glides, and we'll pull up some videos for you guys later just so you guys can see what I'm talking about. And I'll see how they respond. I'll treat the neck. I'll assess neural tension and neurodynamics, maybe even do some treatment if I can. And I mean, I'm assessing everything to see where the restrictions are, where the impairments are, and what I think or what I deem the low-hanging fruit to treat, to see where I can get my biggest bang for my buck. But while I'm doing that, I'm also going to see how they respond to my to my screen or my intervention, which is really my assessment. So if they respond quickly to treatment to the neck or treatment to the shoulder or T-spine, whatever the case may be, I'm like, maybe this isn't frozen shoulder, because a true frozen shoulder isn't going to have that true response. And I would say, don't get me wrong, that you definitely have those outliers. I think I've had a couple of shoulders where like I got true frozen shoulders where I got like 10 degrees of motion back in one day. But I would say the ones that were diagnosed with frozen shoulder but really didn't have it responded well to treatment of the neck and neuroglides and maybe some shoulder stuff.
Mm-hmm.
Yeah, does that kind of answer your question?
Yeah, I mean, other things that besides doing that, and I do a similar approach, is the assessment of the glenohumeral joint. If it's like, I've had a similar presentation of individuals, mostly females, mostly post-traumatic or mostly diabetes. Okay. And I feel like most middle-aged elderly women typically have thyroid issues. It's always hypothyroidism. They can never remember it. They're like, some sort of thyroid thing. I'm like, is it the slow one or the fast one? The slow one. I'm like, oh yeah.
I've gained X amount of weight. Yeah.
Yeah, it's a slow one. Is if you get your hands on a true adhesive capsulitis, that bitch is, that thing's not moving. Like, yeah, that glenohumeral joint, you're testing out inferior posterior glides, and especially if it's the first time you're taking a look at them, it's not moving. For a highly mobile, the most mobile joint in the human body, it's not moving. And if you have no idea how that feels, look at the other side. If the person's been diagnosed with bilateral adhesive capsulitis, I would highly judge that. I don't know if any clinical cases, or I don't know, have you ever seen a bilateral?
Not at the same time. I've seen it, like they have it and then they get it on the other side like a year or two later.
Mm-hmm. After the other one's been resolved or close to it, that sort of thing. But yeah, get your hands in there and like move that joint around. And then I think a good thing I gained from residency is, that active range of motion and that passive range of motion are equal. Is, beyond like capsular stuff and those sort of things, is if it's like they go a certain distance, 90 degrees, and you try to push it some more and it stops at like 93, and you can't go any further, that becomes part of your assessment of adhesive capsulitis. Not always the case. Some people are just that guarded, just that fear of moving when it's an acute painful injury or something of that nature. But if it's been a while and those sort of things, and you're looking at it, it's like, wow, it won't budge. And you get more experience you get, the more you get to feel like this person's scared shitless or is guarding a lot and it's not letting me move their arm, or I'm pushing this thing and I can't move it any further. And that's where that, that difference is probably at. So, those are things I typically will see in adhesive capsulitis. But I agree with you. Start treating some other things, and we'll talk about the regional interdependence study by Wong, and they get into a little bit more of the weeds of like not just treating the cervical or thoracic spine or neural glides. They went into like doing scapular mobilizations, manipulations, AC joint, SC joint, which can affect. So it starts to become, are they responding very well because it's something else, or just from a regional interdependence, we're doing so many things and it starts to free up stuff. So,
and I think I have an understanding that it could be both. I mean, there's nothing
mm-hmm.
wrong with that. At the end of the day, I don't care. If I'm treating anything that can link to the shoulder and they get better, I'm happy, the patient's happy.
Mm-hmm.
I don't always need to know why or what's going on. I mean, I think it's important to know all the factors that play into the shoulder moving properly, which is the neck, the T-spine, the scapula, the glenohumeral joint, the AC joint, the SC joint. You need inferior depression of your clavicle so you can get that end range abduction or forward flexion.
Mm-hmm.
And I could
so
very confidently say that the SC joint the clavicle is probably one of the most undertreated joints in orthopedic orthopedic therapists treat. I don't know why. I guess you just forget about it. But yeah, I will also say, kind of with what we're saying, I have seen presentations of, like, for lack of a better term, a double crush. I know we think of double crush with like a radicular, cervical radicular and like a carpal tunnel, but where that patient had definitely had to have cervical radicular stuff, that their rotation, their whole cervical motion was crap, but the rotation was like 30 to 40 degrees. They had Wiener's cluster. All of it was positive. I mean, positive upward tension test, distraction, positive spurlings, like everything just screamed radicular. But their pain was probably their pain and their motion was also limited too, which was some adhesive capsulitis. And then it's like, did some neck pain, did the cervical radicular lead to the frozen shoulder? Did the frozen shoulder lead to the cervical radic? And I remember treating him, and he I think he's 50. He's actually not my dentist, my eye doctor. And I treated his neck, and I was like, this is neck. I was like, I think you have probably both, but I think a lot of it will clear up with neck. So he was in like the freezing phase. So, I mean, acute pain, just irritable, couldn't sleep, just miserable. I was treating his neck, treating his T-spine, treating his neck. That cleared up, and his shoulder acute pain where he like couldn't even move it cleared up, I would say, within 2 or 3 weeks. It was probably, I think I was seeing him 1 to 2 times a week. So we're talking probably 4 to 6 sessions he cleared up, but he still had the limited range that you would see in adhesive capsulitis. So, I think that was a case where it was both, but we got through that freezing phase a lot faster in only 2 or 3 weeks, where he was at least able to manage it and sleep and function and continue his job of, being an eye doctor and examining, because he said he couldn't even do this. They have the eye thing you look into. They say 1 or 2. I love that skit where they say 1 or 2. I got to play it for you.
Especially towards the end, where you're like, shit, I don't know which one. They both look good. This is a fucking test. Are they testing me?
Yeah. So you're basing your answers what they think you
want. Yeah.
But yeah, so he cleared up with that stuff. And while he had limited motion, it was improving and a lot less irritable, and he was at least able to go do some stuff. And I did suggest for him to go get a corticosteroid injection, because that's what the evidence supports. And that's what I've seen work as well. If it's a true frozen shoulder, get 1, maybe 2 injections. You'll know if it works after the first one. And then, we go from there. One of the few times I will suggest getting a corticosteroid injection.
And that's usually, from what I remember of the evidence, it's usually what the 3 to 4 month marker from onset of symptoms is the best time to implement
When it
a
would be most
corticos.
effective.
Yeah. So
Basically in that freezing phase, or what was thought to be the original freezing phase, was that 3 to 4 month time frame. So
and then,
basically the earlier the better. I mean, someone with acute frozen shoulder, that shit, I feel bad for them. I'm like, just go get it, so you're not in pain.
mm-hmm.
But yeah, I don't know, man. Doctors, I've seen physicians, they're just like, yeah, I'll give this injection. And like the most recent patient I had, she was like, yeah, should I go to PT? And he was just like, if you want. And I was like, what? Why do physicians not feel like we are viable options? Why do they feel? And then he's like, yeah, if it doesn't work in like a month, come back. I'll give you another one. And it's like, so you want the patient to do nothing for a month.
Mm-hmm.
It makes no sense. And it bores my blood. And I think we as therapists need to, 1, educate doctors better. And 2, be able to treat this better so patients know that they come to therapy and not get a fucking injection and rely on a doctor. Because a lot of them, I'm sorry, there's a Louis C.K. skit where he talks about how a physician uses none of his medical education for his advice. And I feel that way sometimes about some of these physicians that just say, oh, injection, wait 2 weeks and do nothing. And they say rest. Like, what kind of fucking advice is that? Refer them out to a competent PT or another medical professional that can help, I guess, your injection be better.
Mm-hmm.
But
no, it goes in along the same, I guess, concept of like, our manual techniques is, that corticosteroid injection, whether it's a true inflammatory process or just the pain relieving effect, it bought you a window. Use it. If you're taking someone who's downright traumatized by the fact of lifting up their arm is shearing pain, and you give them a shot, yes, that might help out their pain at rest or something. But more often than not, they're not going to probably move their own arm. Just from experience and those sort of things. So you just hear people like, I didn't do anything. We know motion is lotion, and, getting things moving. Again, you just want to capitalize on these opportunities. Whether, I went from, I guess being part of the whole team coming out of school to becoming PT or nothing, screw everyone else. I got this, to be more collaborative, being part of an approach, refer out to injections or imaging as necessary. But it's got to be timing, and we need to know what's the best at what times. As you said, you prescribed or you told your client to get an injection at the appropriate times. But maybe it's because physicians or the research out there is that the overall prognosis of adhesive capsulitis, it's a year or 2 years, will resolve itself. And I start to debate that research out there is like, maybe it's taking that long just because we suck at it. We aren't doing the right things to shorten this up. Maybe it doesn't have to be a whole year. I know in the cases where I've had some people, they responded much quicker than that and gotten better to functional levels a lot quicker than 2 years or a year, just in a couple months.
Mm-hmm.
So I think that's that's when you can kind of start to, I guess, abuse the research. And one person study or 2 people study, again, may not be what's best for everybody, but at least the least you can do is try. And then, you go with physicians, and there's other research just with physicians giving a kind of a bad vibe about physical therapy to clients already leads to worse outcomes. If they're like, yeah, go try it, it's probably not going to work, I'll see you in a couple of weeks, versus, hey, I meant, try this. This is definitely going to help you. Outcomes are different. So,
reframing it in a positive light versus a negative light. And I think, that one says a lot about our profession, where it is that sucks that the fact that other professions are like, yeah, try it, or that we see 5 people an hour and somehow it's okay and there's no quality of care, or that people don't follow up and take their profession seriously once they leave school, where they're doing the bare minimum, for whatever reason. So I know people might get mad, but if you're just getting by with your credits every year, you're doing the bare minimum. I mean, people are relying on you to get better, and that's the bottom line. So we
Yeah.
get, life gets in the way and things like that, but try and provide the best care that you can.
Yeah, no, it is people's lives in your hands, whether, people are going to give you probably at most a 2-week window before they drop off. And it's amazing what you can do in 2 weeks or a couple days or a day, or 15 minutes. If you actually know what you're doing. But before we go down that, as you would say, rabbit hole and start ranting and bitching a little bit. But, speaking of other timelines and those sort of things is, manipulations. We were talking about manipulations under anesthesia, manipulations, in the clinic. From what I remember, the research supports it. Anything before 6 months is highly effective. But let's talk about that. My original. Yeah, go ahead, brother Brandon.
Yeah, I was just going to say, we're on the topic where we're talking about where our profession is and what we need to do better. So let's dive into this video. Ah, shit, did I lose it when I closed? Here it is. All right. So I'm going to take over the screen here, if you don't mind.
Yeah, all yours.
All right. So this is actually our upcoming course on lower and upper extremity manipulations. But I included this in because I wanted people to see this is what's going on. And I'm sure this is not the only variation of manipulations that physicians will do, but this is really all that they're going on here. Let me back it up for you guys.
He ended up developing frozen shoulder after his injury. So before thinking about doing a decompression, we're going to try
like a fairly young-ish male.
He had frozen shoulder.
Suspicious.
All right, look, this is all that manipulation under anesthesia is, which, by the way, this is the long axis variation, which is more dangerous because that leads to humeral neck fractures or head fractures, one of those two.
And labral tears and rotator cuff tears and pretty much everything bad.
We were talking, but he has some cracks. And then he externally rotates it. He gets some cracks here. And then that's it. The rest of the video, he's just ranging it. So I'll save you guys that. But that's all that he's doing. And you're telling me we can't spend some time learning how to just manipulate?
Our second technique will be
so let me lower that.
Thrust technique.
And actually, that's our second one. Let me back up here. Oh, sorry. I'm still learning technology, guys. Let's go here. How do you get this little bar to go down?
I think you just don't do anything near it. And
there you go.
There you go.
All right. So, look, I have my hands around the patient's. Let's go back because you guys missed a little bit of it. So I'm using a towel there to block the scapula from winging out because these patients are obviously going to be bowed down and tied down. My hands are going to be around the humeral head here, right on the joint line. I want good control. And I'm just mobilizing a joint, and then I add a little thrust there. You do that with impatient tolerance. You don't have to be extremely forceful. I'm not asking you to do what the physician does where they bring the arm straight back, but just basically mobilizing it, adding that quick impulse. If you get some cavitations and some scar tissue breaking up or adhesions, cool. Or maybe it's just a neurophysiological reset, and I'll save that topic for a little later because we'll talk about that. That's an inferior glide. This is a lateral one, so hopefully with the hopes that we're going to improve abduction primarily, but you probably get some carryover as well. So, and just so you know, obviously my model here, she does not have frozen shoulder, but I've done each of these techniques to my patients with frozen shoulder with good success. And obviously maybe not do it to everybody. You don't do it when they're in extreme pain. You have to gauge their irritability levels. And I would say the first two, especially the first one, is good for somebody maybe who's more irritable. And these last two are probably good for somebody who's less irritable. But these are just 4 variations I wanted to share with you guys because some of the manipulation talks about it, and Jeremy's going to talk about that next with some of his articles. And, you know, that is that. So not to say, and Jeremy, I know you said that, you know, you've gone from being a team player to PT only to now you pick and choose because you've been around the block a few times and you know, but like it is the risk of sending a patient to get a manipulation under anesthesia worth it when you could probably do it in the clinic yourself? Obviously not doing it under anesthesia. Hopefully we don't let the patient get to the point where they need to go for a manipulation under anesthesia. But this is where we can be a viable option. And I know there's financial gain and incentive for a physician to go in the OR room and charge for surgery for something like that. But aside from that, I mean, if you're not performing manual therapy and practicing and honing your skills to be able to perform something like this, I think you're doing your patients a disservice and not doing it. But I'll pass it off to you, Jerry. I know you had a couple articles that looked at manipulation and regional interdependence.
Yeah. So thankfully, I haven't had to make the refer out to a manipulation or anesthesia for all my clients. One person I tried to, it was a knee way back when, and they said, no, it's better than what we thought, so stick with it. So I typically have higher, you know, expectations than most surgeons or those sort of things. They said, you know, stick with it. So not to toot my own horn or anything like that, but mainly is because we're doing things like this. Is, you know, how different is what you're doing, which is also safer than what that other, you know, video was.
Yeah, they're not going under. That alone is safe.
Yeah. And again, like how often are actually surgeons doing that? Like they showed, like now that, you know, those MUAs are now done similar to what you did, was just called transitional manipulation versus a long axis style. But think about that. If you're, you know, mobilizing, you know, 5 people's shoulders a day, doing these high velocity stuff, who's probably better at it? Patient's probably more comfortable with you because you already developed, you know, relationship over multiple weeks or months. And let's face it, you probably have quicker hands and those sort of things. Obviously, they have the benefits of them being lights out. So that's why I always say
these patients come out sore as fuck afterwards and not being able to move their arm for like a week.
Mm-hmm. Yeah. And then they need like therapy, like what, like 5 days a week?
So now I think
that's a protocol.
5 days a week intense. And for what? When I could have done the same thing, they wouldn't have been sore or as sore. And yeah, there's just less risk. I'm not going to fracture your arm. And I do it every day. I mean, we manipulate every single day. But anyway, not to make this about what we do.
Yeah, what we do. Yeah. But no, it's just, you know, kind of our point there. But I always say we should, as therapists, screw the whole, you know, our next responsibilities thing is we should either be able to have physical therapy as a BYO, or we should be able to prescribe laughing gas. Either or, you know, local knock them out for a hot couple minutes. Nothing like, you know, where they need a PICC line or anything like that. But, you know, I think that would be best. And then for those special cases, either laugh them up or here's a couple of shots. Let's get to work.
Or let us go into RR with you and we'll do the manipulation.
Which I think Scott did in our one of our faculty of our fellowship, our residency. He had the opportunity to do that, which is kind of cool.
Awesome.
But yeah, so in regards to, you know, manipulation versus mobilization, you know, both are, you know, probably better than nothing. But in regards to, let me see if I can put that up. And in comparison, this study, which we got in residency, comparison of high grade techniques, which you demonstrated both high grade and low grade mobilizations, found that, manipulations were superior in, gaining range of motion comparison for people with adhesive capsulitis. So, it's something that we should, implement. I don't think it's taught much too. Like
Manipulation of
high
the shoulder.
velocity. Oh, yeah, the shoulder. Like, when is that ever taught? I don't think I've ever taken a con ed class, and I've taken a lot of con ed classes. Obviously, we've done residency and fellowships and those sort of things. But outside of that, I haven't had any students that had any idea of these sort of things. And, if that is what is being used in surgery to free things up, why aren't we doing it in the clinic? That's, in theory, one of the more effective techniques. If shit hits the fan, all right, we gotta knock them out and do this technique. Why can't we do our versions of it in the clinic? So yeah, go ahead there, Brandon.
Yeah, I was just going to say, you bring up a great point with why isn't it taught? And I was just, as you were saying that, I was reflecting. I was like, yeah, I haven't learned it in any courses. We didn't learn shoulder manipulations in residency, other than the fact, I can't remember if they said it there, but basically there's a saying, if you mob it, you can manip it. So then it was like, all right, well, if I'm mobbing this, let's kind of open up the reins here a little bit. I think I picked some up along the way with some mentoring with fellows, and I think in AOMT, and then a lot of it was just self, I guess, learning, just kind of playing around with some stuff too. So combination of those three there, and which is why I was like, all right, we need to make this course because it's not being taught there, and it's such an effective tool, especially for clinicians to learn, not even just for adhesive capsulitis, but for other diagnoses such as radial head, scaphoid lunate, scaphoid, cuboid, fibular head, things like that. So, I mean, you could really do the whole body here.
Yeah.
You mind switching off screen share? I want to show an article as well. A couple articles, actually. I don't know if you had anything to say there.
No, I mean, yeah, I think it's something. Yeah, you hit all the points. And I'll prep the regional interdependence article as well.
Yeah, so here's another one by Boyles. I mean, this one's a manipulation file, regional interscaling block as well. But, the articles that they talk about here and the patients that improved were the ones that got, here you go, Jeremy, translational manipulations. This technique is utilized to be safe and effective because small amplitude, high velocity, short level arm are better than long level arm techniques. Right. So we saw in that video before that they use a long level arm. Well, we could do a shorter one. So that was kind of the evolution there. I mean, it kind of goes into some case descriptions there, but I guess, Jared, we can link these in the podcast episode if you guys want these articles, or you can just email them for us. But just while I have the screen share before I pass it back off to you, this was a great one. I love this. I went through this. I think this article came out when we were in residency, and I was dry needling like a madman. And I was like, dry needling. But then, this is not to say this is about dry needling. This context. Like, I love these case studies. Like, people say case reports aren't good research because they're like low on the totem pole. I think that's a crock of shit. I got insight to these three gentlemen's thought process by reading this article. and what they did here. And I was able to, at that time, compare, is my treatment like one of the best people in this industry, what he does? That was kind of my thought process when I was reading this. Do I match up to Tim Flynn and Derek and Shane? So, look at what they do here. The exercises, over the chair thoracic extension. What did that do? And we've talked about this before, Jared, how we layer our treatment. Well, that's following up their thrust manipulation to the CT region. So cervical region, thoracic region, and CT junction. Session 2, same thing. They did that, and they added the thoracic. They looked at AC and SC joint mobilizations. They looked at passive range. I mean, this was their treatment initially, was all manipulation regionally to avoid an irritable patient at the shoulder. And then as things started calming down, they started working on glenohumeral joint and passive range, and they integrated dry needling, and they progressed them exercise-wise. But when we talk about regional interdependence, I'm starting with the neck and T-spine. And after you share your article, I'll jump back into why we should manipulate the T-spine for a lot of patients with shoulder pathologies. But hopefully that gives you guys some insight on, how some really skilled clinicians are treating. And this is not a randomized control trial, but they had great sessions or great outcomes in only 13 sessions here. So just give you guys some perspective.
Yeah, and if anything, that this does, and something I kind of look at from when I was a novice clinician to where I'm now, is just overall pain. I still feel like, the range of motion improves, but, most of these people are pretty debilitating pain, can't sleep, can't function, and those sort of things. And what I can say is starting implementing these things, and that painful cycle that's supposed to last for months, that'll subside fairly quickly. They'll get back to like, I can sleep a little bit, I can sleep better. It doesn't bother me throughout the day as much. It's when I reach up and try and achieve new ranges of motion. So that's achieved pretty quickly with, potentially like these regional interdependence or thrust techniques.
And with that, our goal shouldn't just be pain. What's the why? It will decrease pain so they can what? So they can sleep, so they can reach into a cabinet, so they can pick up their kid. So like tie your goal, especially your own clinicians, tie pain to a certain activity. You won't get denied as much if you're tying that pain to something specific, and you're saying, I'm performing this technique, so we improve this function. And now you're drawing that line and connecting the dots for not only documentation, but if you have to send an authorization or get on a peer-to-peer call or whatever the case is. Now you have a reason where you can sit there toe-to-toe and basically argue with those idiots that try and deny you visits, and not just say, I have to fix their pain or the range of motion. Well, why? And what are you doing that's adding value to that? Because you can't just say exercises for all your non-manual therapists that are there, because they'll say, give them a home exercise program. So, taking it that next level.
Absolutely. And so, hold on, I'm just trying to put this back up. So we're talking about the regional interdependence. This was a study by Wong et al. This is a case series, and we were talking about, he also he's involved in a systematic review, kind of debating the things of whether frozen shoulder kind of in those stages, or are we doing things right. But in this case series, which I think was at least 5 clients, multiple weeks, 9, 13, 2, 30, 17. What they did was a lot of manipulations, and I'll show the outcomes, but these are initial findings: flexion, abduction, external rotation, your classic findings. I believe all these people in this were referred by physicians, so it wasn't this is a maybe sort of thing. This was more obviously, again, there's some debate on, whether our physicians are diagnosing correctly, but based off these findings and stuff, it would suggest, that these people had adhesive capsulitis, but their approach, let me see where they were at. That passed by it? Yep, I did. 4 regions: the shoulder girdle, SC joint, first rib, AC joint, glenohumeral, humeral, rotator cuff, scapular, thoracic, and the spine were all the areas where manual therapy was applied. So they did a variety of high velocity, low amplitude thrust, mobilization with movements, osteopathic manipulations to those areas, and their outcomes were pretty good. As how much they increased were a group 62 degrees for flexion, 100 for abduction, 66 for external rotation. So and 14.8 sessions in a average of 7.6 weeks. So again, using that regional interdependence approach, can result in just not, again, also those range of motion sort of things. So these are the techniques that they received. I try to be a little bit more specific, and maybe they were as well, of, I try and find which is the best technique. I'm trying to assess as I'm doing it is, well, that resulted in the best gain. I want to keep hammering home that one. Maybe I'll evolve it a little bit more. Maybe a thoracic spine manipulation did good. I did, like, let's say the pistol or something like that, or the seated. All right, maybe I'll play around with a couple different more and build off the top of it. But, in this group, it seemed like they did just a variety of all ones to multiple areas. And, how many of, us can say in 14 sessions and less than 2 months were, again, those type of range of motion measurements in the 5 clients that they've had, in your most recent 5 clients. So I think it's something we definitely need to implement. Obviously tougher when it's someone over a distance to telehealth.
And I think, when it's over distance, it's how can you get creative? Can you use foam rollers to address T-spine impairments, whether it's extension, rotation, combined rotation or extension? Can you use super bands? Let me pull this up for you guys here. Using especially super bands are mainstream now, especially in the world of CrossFit and stuff. Like, have patients buy these. These cost $10. They can anchor it to a banister or a door. They can do these different shoulder mobilizations or stretches, however you deem fit. This is your SSMP here, or SSMP that you like, Jer. I'm having the patient do a posterior glide, and you could have them actively go into forward flexion, or just hold that in a sustained glide. Lateral glides here. Inferior glide is another SSMP one. Now you're working combined motion, functional internal rotation with a lateral glide, functional internal rotation with distraction. Cross body, there's been debate, is cross body stretch better versus sleeper stretch?
Sure.
Yeah. So, you guys can get creative here. Functional external rotation. These are all things you can easily send them this stuff, just demonstrate it for them, explain it to them, walk them through it. This is how you incorporate manual therapy, via distance. While I'm here, and we're talking about, I know you're saying you do a lot of T-spine manips, Jer. We have this article here by Cleland in 2004 looking at the short-term effects of thoracic manipulation and lower trap muscle strength and activation. So they found out after you perform a thoracic manipulation, EMG activity and strength of lower trap increases. Now that's what they were looking at, was lower trap. I'm sure you can probably extrapolate it to serratus or mid trap or rhomboids or whatever. But, couple that, perform a manual therapy technique with this article here by Mike Ronald, which looks at the best exercises to perform for rotator cuff and periscapular strength exercises. I think he has here we go.
Yeah.
And you do some manual therapy, you have them hop on a foam roller, and then you do these exercises based upon what you think their biggest impairments are. And now understanding that manual therapy is going to help with muscle activation, now we can now follow up with some lower trap and middle trap exercises and get a bigger bang for our buck. I think that's how you really put all this stuff together in terms of, not only in treatment, but telehealth, using manual therapy versus trying to make the patient more independent using, self-mobilizations or a home exercise program. You have this article here by Yang. It looks at scapular mobilizations, scapular manipulations. I'll pull up a video for you guys here on scap stuff.
And for our viewers who are listening in and obviously can't see the videos, we post this on our Facebook so you can watch it later. But just to keep the meantime, Brandon mentioned shoulder SSMP, which is the shoulder symptom modification procedure. If anyone wanted to look that up, that's by Jeremy Lewis. Just a way to just modulate, change people's symptoms as they're doing a painful task for the shoulder. Look at that stud.
Try and limit the volume here on this because I voice over
scapular
these.
Protraction manipulation. Have the
Is this the volume? I guess that's the
Yep.
volume. All right. So there's a pause here because these are instructional videos. So I'm voiced over. I'm talking you through how to perform these techniques. So I pause it so you guys can see where my hand placements are, my setup, so you guys can do this on your own. But if you look here, there's a protraction manipulation. I have the patient here, and then I thrust up. I'm not going to show you all of them, but you can do a posterior tipping one. You can do a retraction one. You could just do scapular clocks. I mean, you can really get creative with it. You could do a depression one. And that, these patients tend to be the most gunked up, right, Jared, where they're just, that whole area is just bogged down. I think that's what you were saying earlier with, are they getting better because you did regional interdependence treatment, or, are they getting better because we just did a whole bunch of stuff? But yeah.
No, those are good pearls of wisdom there. Good videos of, again, at least play around with it, everyone. As Brandon said, he got from someone, anything you can mob, you can manip. If you're just not comfortable with, manipulations, haven't learned any, try and just add a couple quick thrusts, as long as the patient's, cleared and everything like that, see how it goes. But what I guess the case point there is, seems like when we do some sort of manual, interventions, people seem to do better with this cases. So I think that's about it there.
This was a long one. We got into it. So
yeah,
which is good. I liked it. I thought this was a very good podcast for us. Hopefully you guys found it beneficial as well. Any questions, please don't hesitate to reach out to us. Jerry, you want to tell them our handles? That's usually your job. I don't want to take your thunder.
Yeah, so we're at Manips and Sips on Instagram and Facebook. You can find me at The Decent Doctor or at Trifecta Therapeutics. I'll respond to either. And Brandon's at Think Like a Fellow and at Pursue PT Now. We'd love to help out, nerd out about this sort of stuff. If you have things that you argue against or have different intervention strategies, we'd love to hear it. And but yeah, thanks for listening in or watching in, and yeah, cheers everyone.
Cheers, guys.